Thanks everyone for coming, and for those joining online. This is my OSP presentation entitled Stories and Statistics. Hopefully the title will become clearer once we progress through the presentation. And a little introduction. I mean, everyone in the room knows me, but for those online who may not, my name is Anandin Mbikaraja. I'm a lecturer in the discipline of psychology and core member of the Centre for Aging Research and Translation at the University of Canberra. And I'll probably leave the introduction there because you're going to hear me talk for about an hour, so you'll be well acquainted with who I am by the end of it. Before we get started, I'd like to acknowledge country and acknowledge the Ngunnawal people, who are the traditional custodians of this land in which we're gathered, and pay my respects to elders past, present, and emerging. I feel most connected to country when I'm on country. I've recently gotten into trail running, and this is a photo from the top of Mount Ainslie. So it definitely gives me more of an appreciation for the traditional custodians of this land. So OSP, or also known as my research sabbatical, it was a period of a little over 6 months from December of last year to end of June of this year. And part of that was at Frontier at the Brain and Mind Centre at Sydney University. And Professor Olivier Piguet was my host there. And then the other half was at the National Centre for Epidemiology Research and Population Health at the Australian National University with my host, Professor Nicholas Sherburn. Now, I've been to a few of these talks, and I've seen when people come, they have like these great photos of places they are overseas, and really beautiful landscapes. I'll be honest with you, for my OSP, I was mostly at a desk, pretty much exclusively at a desk. And I had put photos of me at my desk, or just my desk there in the presentation, but I didn't think it instilled a lot of inspiration or admiration for the OSP journey. However, I did come to the compromise that a beautiful thing about OSP is that it's mandatory to take at least 2 weeks of leave. And so I thought, if you'd indulge me, I'd start off by just talking about the beautiful leave that I took before going on OSP in December last year, where I went to Germany. And I went to a small town in Germany called Riede, and it's got a population of about 20,000 people. And when looking up what to do in Riede, I found that the top tourist attractions are, there's a windmill, which is there in the small town, and there's also a church. And so this is the church. I didn't get to see the windmill, but this is the church that's there. And you may be asking yourself, why did I go to this small town? And the reason is my wife, when she was in high school, did exchange with someone from Germany who we went and visited, and they've been in touch ever since for 20 years. And so we went over there with our whole family and spent time with them. And so it was really beautiful experience. And this church is like hundreds of years old, and it is nice because it was a really small town, and the church was like the centerpiece of the town. And inside there's an organ. They had an organ player come along and play the organ. So it was a really beautiful experience. And it was great for my kids as well, because they got to play with my wife's friends' kids, and of course there were language barriers there where they didn't speak English and my kids of course didn't speak German, but you know, laughter sort of transcends all of that, and so that was really beautiful to see. And the beautiful thing about being where we were located in Germany is that with a car you could drive to Paris, you could drive to all these other locations. And so yeah, it was really amazing. We got to see the Louvre in Paris, and it was all really, really incredible. So it was a nice experience to have with my family. We spent 4 weeks overseas, and really a great part of OSP. So let's temper the expectations there. That's probably the excitement when it comes to traveling overseas. My OSP, as you know, is in Sydney. But you know, there were a lot of benefits. I got to work with these beautiful people that you see here, and this is the team at Frontier, many of who are online. So hello to Frontier members there. The man on my left in the photo, who's in the shirt that's even better than my bird shirt there, is Professor John Hodges, and he started Frontier in 2007. So Frontier is a dementia research clinic, and it's the largest specialist frontotemporal dementia research clinic in Australia. And I'll talk more to what frontotemporal dementia is as we go through. And what's really impressive about the work that they've done is that they've curated a data set over 1,300 participants to date. And many of these patients, they come back for follow-up assessments and also for consultation. And the person on the right there is Professor Olivier Piguet, who hosted me and has taken on the leadership role of leading Frontier since John's retired, is still active, but retired. And really what's impressive and amazing about what Frontier does is it's a dementia research clinic, so they conduct research, but they also provide a really meaningful service to the community members there in Sydney. And so they help with facilitating diagnosis, but also prognosis and fundamentally connecting people to networks and caring for those with frontotemporal dementia and related conditions. So that was at Sydney University. And before I go any further, I thought it'd be useful to frame this talk, and also when I was framing my application, you write down all these goals that you have, and really the sort of framework goals that fed into all the specifics were that I had two. One was to strategically expand my program of research to better align with CARET. I mentioned I'm a core member of the Center for Aging Research and Translation, and I'll speak to this point a bit more in detail in a moment. But then the second framework goal that I had was I wanted to enhance my expertise in statistics and frontotemporal dementia. And the reason for this is because it's very, I think it would have been easy for me to go on OSP and just keep doing what I was doing. But what I really wanted to do was actually upskill and actually learn something, bring something back to the university, and also enhance my own capabilities and abilities. And one key thing that sticks out in my mind as to what I really wanted to do over the last few years was to enhance my expertise in Bayesian methodology. And so what is Bayesian? Well, Bayesian analysis essentially allows for the incorporation of prior knowledge from literature. And also you can embed clinical expertise and living experience into the models. So models can be updated continuously as new data becomes available. So it's really a strength of this sort of statistical framework. And you can make direct probability statements, which is probably the most exciting part of Bayesian analysis. So there's a 95% credible interval, which allows you to say something very directly. Like there's a 95% chance that the estimate lies between this range, right, of the lower and upper bounds of that range. Whereas in frequentist confidence intervals, it's a bit different. What they represent is that if you were to run this experiment under the same conditions and the same over and over again, like 100 times, 95 of those confidence intervals would include the true population value. And so they're different. I think the credible intervals in the Bayesian framework allows for just a more intuitive and direct assessment to be made. And a beautiful thing about Bayesian analyses is that the use of priors allows for stable estimations with limited data, which is a thing that comes up in many research that's being done at UC, but particularly in psychology discipline. There's low sample sizes, and so when you use Bayesian estimates, the advantage of using prior knowledge is that it allows you to have this sort of stable estimations, even with limited data. And there's this great book called The Theory That Would Not Die: How Bayes' Rule Cracked the Enigma Code, Hunted Down Russian Submarines, and Emerged Triumphant from 2 Centuries of Controversy. So it rolls off the tongue, that sort of title, by Sharon McGrain. And it's a great read. And fundamentally, Bayesian analyses has been around for so long because it just works. It works for supporting decision-making. It works in allowing predictions to be made accurately. And so this book sort of articulates that, but it really is a framework that works effectively in practice. And there's also the Book of Why, which is the new science of cause and effect by Judea Pearl, which was made famous many years ago, that shows how Bayesian sort of thinking allows for this more causal inferences to be facilitated and made. And so how did I learn this? Well, I didn't really attend any course or formal workshop. I just started by looking through some textbooks. So the first was Bayesian Data Analysis by Andrew Gelman and colleagues. And this was a really difficult textbook. It made me wish I paid more attention to integration in high school. It was very heavy in mathematics, but it really gave a detailed and good foundation and framework for me to learn. And the great thing is Aki Vitari provides some YouTube videos that accompany the textbook. So that's really useful. But when I was very lost in the textbook and I needed to just sort of step back, the Statistical Rethinking textbook was a very useful resource for me as well. I also engage in using artificial intelligence, of course, so Microsoft Copilot, ChatGPT, Claude, Perplexity, and more to sort of check my understanding. I would to learn more, to identify if I was on the right track with my thinking. So it's a really useful learning tool and something that I use. And I also had discussions with varied colleagues who have expertise. And when I say varied, I mean varied. Like there were people I knew from ecology, people in electrical engineering. These are sort of the disciplines in which they were using Bayesian analyses, but people around me just weren't using it. So it was useful to have those chats, and even people in marketing who use it for prediction models as well, this sort of framework. But the best way that I learn, in addition to all of the above, is really project-based learning. And so that's what takes me to the question that I wanted to address using the frontier data set that I mentioned earlier, which is how long does it take for people with dementia to receive a diagnosis after first experiencing symptoms? That was the key question I wanted to address. And before I go into that question in more detail, I just want to talk about how that question represents a fundamental expansion of my research focus. So to date, a lot of my research is focused on the prediction of risk factors for brain health and dementia. So I've looked at sex-specific factors, primarily because women have higher rates of dementia than men. And this isn't fully accounted by age. And so I was investigating questions such as the contribution of menopause and the changes around menopause, hormone replacement therapy, cardiometabolic factors such as fat mass and lipids, genetics, including the apolipoprotein E genotype, which is we all have, but there's different alleles or variants of it, E2, E3, E4. And presence of the E4 puts people at higher risk of dementia. And so I was looking at how this sort of interacts with all these other factors. In addition to lifestyle factors, I've got a PhD student who's working at ANU, focusing on sleep and physical activity and brain health and dementia as well. And so this is really where a lot of my work is and continues to be, but I recognize that much of what I did, whilst it fits within the CARET dementia cognition stream, a lot of what CARET does is person-centered care. So it focuses on the people, lived experiences of people. And so I recognize that by expanding my research scope to look at the other end from prediction to diagnosis, it allowed for a better integration with CARET. And that's also a really important question that I found. So early detection, accurate diagnosis, it's really crucial for access to support services, care planning, and targeted management strategies. It can reduce long-term healthcare costs by facilitating more effective management and prolonged independent living, and enables clinical trial participation. You may have heard in the news this year about the new Alzheimer's disease drug that was released. Well, to be eligible for this drug, you actually have to be in the earlier stages of Alzheimer's disease. Those in the later stages of Alzheimer's disease are not eligible. So this, again, emphasizes the importance of timely diagnosis, because if the disease is progressing in that time where they could have been diagnosed earlier, then it can impact the access to these drugs. And so, of course, when available, the implementation of disease-modifying therapies to treat or slow down disease progression. So those are really the drivers of what motivated that research question. And so the question isn't as simple as it may seem, because dementia is a heterogeneous condition, and it includes Alzheimer's disease and frontotemporal dementia and vascular dementia, all of which have distinctive clinical presentations and trajectories of disease progression. And so hopefully this doesn't overwhelm you, but I think it's important just to give you a sense of what the key clinical features are across these different syndromes, and to show how they differ between all of these different forms of dementia and related neurodegenerative conditions. And so for Alzheimer's disease, which is the most well-known and commonly thought of in conjunction with dementia, this is where people may find difficulties with recalling events, so episodic memory difficulties, difficulties with planning, and also you may have heard that people you know who have dementia have increased wandering, or they may get lost. And this is as a result of the visuospatial dysfunction that can occur. But there's also an atypical form of dementia called logopenic progressive aphasia, which includes impaired word retrieval and sentence repetition that can be impaired. And then what I want to draw your attention to is that the next four relate to frontotemporal dementia, and you can see that there are differences in the presentation across these different types. So the most common is behavioral variant frontotemporal dementia, named primarily because of the behavioral changes that occur in people with BVFTD. This includes disinhibition, so they may become more socially inappropriate, they may lose motivation, there's a loss of empathy for others, dietary changes, and limited insight into the changes that are occurring with their condition. And then there's the language presentations, including PNFA, progressive non-fluent aphasia, and semantic dementia. And for semantic dementia, that includes word finding difficulties and difficulties with like recognizing objects and object knowledge. Then there's also this concurrent FTD and motor related syndromes where there's concurrent cognitive and behavioral changes and progressive motor weaknesses that occur. And then in the Frontier dataset, they also have access to people they've seen with movement disorders, including cortical basal syndrome and progressive supranuclear palsy. So this is sort of the complex architecture around many dementia subtypes and also related neurodegenerative conditions. And so the hypothesis was, well, if you look at all these differences in their clinical presentation, then it's likely that there'd be differences in diagnostic timelines across these conditions that relate differences in their underlying disease mechanism, clinical presentation patterns, and maybe even diagnostic complexity of diagnosing these disorders. And so when we look at the available literature to date, many studies have either they group all the dementias types together, or they focus specifically on Alzheimer's disease, the most common type of dementia. They may focus on younger or later onset dementia, but this is sort of an arbitrary threshold. Most people set it in Australia set it to 65. This coincides with the date at which people typically retire. But in studies, it could be anywhere from 45, 55 to even older. And so there's no sort of standardized definition because the criteria can change. And then also studies have focused on FTD as a whole, but I've shown you already the complexity within FTD and the different subtypes. And it really shows you how access to data is important for answering certain types of questions. And the data set that's available at Frontier allows for a much more nuanced investigation of differences amongst FTD subtypes in Alzheimer's disease. And so there's, limited research in this space that's investigated it. And really, I think that this heterogeneity is what has contributed to the mixed findings in the literature today. So some studies report no differences between frontotemporal dementia and Alzheimer's disease in terms of time to dementia diagnosis, so it's all the same. And others say, actually, for frontotemporal dementia, it's a longer time to diagnosis than those with AD. But those estimates range from somewhere from 4.5 months to all the way to almost 2 years, to 20 months. And so what's interesting is, there's a lot of research I've shown you already in this area, but despite that, none of those studies have used the evidence available from the previous studies to inform the estimates in the model. And so this is where, from what you understand of Bayesian already, you can integrate a Bayesian framework to incorporate the estimates from that prior studies to inform it. And this is important for many reasons, including the fact that it doesn't depend on large sample size approximations and gives you precise and robust estimates. But speaking of sample size, Frontier is really impressive in its data set. This is just a proportion of the individuals included. And one thing I want to draw your attention to is that it's not typical of a dementia clinic, right? Frontier has a name that it's made for itself in terms of frontotemporal dementia, and this is why you see that for Alzheimer's disease, it's 125 participants, and behavioral variant, the most common type, it's 163. It's because in some ways, it's not representative of the prevalence of these conditions in the population. But there's quite a large sample size available because of this. And the beautiful thing about what's done at Frontier is every single patient who comes in, they get the exact same standardized protocol the first visit, which is comprehensive multidisciplinary clinical assessment. They get neurocognitive examination, they get a structural brain MRI assessment, and then also they have consultations with a neurologist, and you have the care and informant report. And all of this can inform the diagnosis which occurs when it comes to diagnosing these different conditions. And so For time to diagnosis, there's really two key measures, which is the symptom onset, like when people report having the symptoms start, and also what we've just discussed as to the date at which diagnosis occurs. And so symptom onset was obtained from the participant or carer during that assessment. And then the earliest date of diagnosis with Frontier was defined as the first occurrence of a diagnosis that had met criteria for that condition. And so the time to diagnosis is just the difference between these things, symptom onset to date of diagnosis. But what's really interesting is when I looked at this, it was very apparent that there's many participants who don't know precisely the date at which symptoms started. And that's reflective of these conditions. It's an insidious onset for many of them. And what that means is that it's a slow, progressive onset that occurs. Whereas for all the studies that I was looking at, none of them really directly addressed this question at all. Like, what is the level of precision that's there? And so the method that I went about addressing this was ensuring that the month of onset, if it was unknown, was imputed to July of that year. So that gives you a maximum of 6 months of error in sort of the estimation. And if you think about, because there's no evidence to really indicate that it would be more or less likely across months of the year, then it would be more uniform that you'd expect across the different months. And so that was the approach, but I was really, really surprised that there were no studies that have looked into, well, what is the level of uncertainty around the symptom onset? It's sort of not really asked. And so I'm currently leading a research project that's investigating this question as to what is the degree of uncertainty that's there and how have studies addressed it. But in my review of this specific topic, I've found that no real clear method in the papers there. And so this is the time to diagnosis across the different groups. Really, all I want to draw your attention to is sort of the distribution is non-normal, right? So it's typically the trend across all the conditions is that people are diagnosed in the first few years, and then there's sort of a variation in terms of the tail of how long it takes to diagnose the remainder of the participants. And so, but that's another important consideration because means and standard deviations are not appropriate when quantifying this sort of data. But again, this is another factor that has not been closely investigated in all studies to date. And so the Bayesian approach, I put up here some R code. I hope it serves the purpose and doesn't disserve it. But essentially, I wanted to put this here because Bayesian analyses can seem really foreign and non-approachable, but I think if you see it in person, it can sort of make it seem more accessible. And really, all this is typical R code that you see. The first line calls the package, which is the BRMS package that's used. The second line calls the BRM function. And then the third line allows you to show that it's a regression model as you would do any other regression model in frequentist framework. So you have the outcome variable, time to diagnosis, and then your independent variable, which in this case was diagnosis groups. The family is sort of the distribution. And I chose a gamma distribution because it's well suited for data that's continuous and positive, because you can only have a diagnosis greater than 0. You can't be diagnosed before symptom onset. And it's positive for positive skew data. And that with the shape parameter gives you this distribution of these sort of images that you see here. So that's all that is. So you specify the distribution. Beautiful thing about Bayesian analyses, it allows you to embed sort of bounding as well. So you could say, well, it doesn't make sense for values to go less than this. So you can actually embed this sort of bounding within your models. And then the intercept. So this is where these are all the priors. So this is sort of the additional step that you do in Bayesian analyses. And the priors that are here, I was able to look at all the evidence today, and I could see that on average, the time to diagnosis for Alzheimer's disease was about 36 months, so 3 years. And so I put that into the model. And then given the available data and the mixed evidence, I centered the effect at no difference between the groups and the intercept, which is Alzheimer's disease. So the sort of structure of the diagnosis group is similar to frequentist. And then here is just the sampling method at the end, and the C just is for reproducibility. But I can hear I'm already losing people, so I'm just going to move past this slide and just go on to the main findings. So, but hopefully that is of useful. So the main findings are, firstly, the time to diagnosis for Alzheimer's disease we found was, in fact, 3.35 years. And so that was interesting in itself. But what was fascinating as well was the fact that there were longer delays experienced by certain forms of dementia. So it wasn't consistent across. So for those with behavioral variant frontotemporal dementia, the most common type of frontotemporal dementia, it was about almost 2 years greater than it was 14 months, almost a year greater than those with Alzheimer's disease. And for those with semantic dementia, it's about 10 months greater. And then those with the concurrent FTD, MND, the cognitive and motor symptoms, they had an earlier time to diagnosis. And there was no difference between the other groups. So that was, I thought that was interesting. But I was interested in another question as well, which was, are there differences that occur in time to diagnosis between sex, men and women? Is it that men are diagnosed earlier or women are diagnosed earlier? And we found that for behavioral variant frontotemporal dementia, there's this really clear effect that occurred, which was that though men with behavioral variant frontotemporal dementia were diagnosed 2 years later than women with behavioral variant frontotemporal dementia. And so the biggest thing with Bayesian analyses people always ask is, well, how do you know how the analysis would change if you change your priors? But you can conduct sensitivity analyses. So you run them again with alternative priors, and they yielded consistent results. So it was shows the robustness of findings to prior specification. And so what are the reasons for these results? Well, behavioral variant frontotemporal dementia, when I was speaking with neurologists and other researchers in this area who are well familiar, it was immediately apparent that it's quite clinically complex to diagnose. So many of the symptoms overlap with psychiatric disorders. And also the criteria that's there may be excessively stringent. And I found this as well when I looked into those patients that weren't diagnosed on first visit, it was at the subsequent visit. And of those, the highest proportion were those with behavioral variant frontotemporal dementia. So they were more likely to require repeat visits before getting a diagnosis that met criteria. Semantic dementia, it's typified clinically by word finding difficulties for uncommon words. So you can imagine how in conversation, perhaps there are compensatory mechanisms that support the comprehension. And so you don't need to understand every word. And so it may not be detected by either the person themselves or the person they're conversing with in the early stages. And limited awareness about FTD. Many people are not familiar with it when it comes to dementia, and so this could have contributed to diagnostic delays even in physicians and radiologists. And so for FTD MND, the earlier presentation were likely attributable to the concurrent motor and cognitive symptoms that are there. And the sex differences were really challenging to sort of try to tease apart. I think fundamentally more work is needed. We don't know, but these sex effects weren't previously detected. And so I first went through the process of thinking, well, maybe it reflects some sort of difference in healthcare seeking behaviors. Maybe women are more inclined to seek assistance with their health than men, and that supports some of the literature. But I would have expected to see this effect across all the different dementia types, not just behavioral variant frontotemporal dementia. So I think what's more likely, and when I speak to others, is that there's possibly social cultural factors influencing the recognition of these symptoms. So behavioral variant is typified by behavioral changes, and I think fundamentally in men, that may be more attributed to personality traits, those changes that occur, whereas in women, it's seen more pathologically. And so it also reflects when men are carers of women and women are carers of men. Perhaps when women are carers, they're less likely to, they're more likely to stay at home and less, when men are when women are carers, they're more likely to stay at home and have that assistance and vice versa. But fundamentally, we don't know, and more work is needed. And really, when I look in the literature about not only sex differences, but all sorts of risk factors for time to diagnosis for dementia, there's not a lot that's there. And that really is what led to my work in engaging with people with lived experience for my research. And so really, not all barriers and enablers to timely diagnosis are known in the published literature. And the beautiful thing about Bayesian models is that they can integrate the experiences of people with lived experience in the priors. And so to truly reflect the diagnostic journeys of people living with dementia, it's essential to engage directly with those who have navigated this pathway, and sort of fits in nicely with what Carrot has already done in this space when it comes to their research. And so how did I go about this? Well, I started with connecting with the Sydney Dementia Network Lived Experience Expert Advisory Panel. So that's the SDN LEAP. And this is a panel of people who are living with dementia and they're carers, and they provide input on research projects. So I said, hey, this is my research. These are the questions I'm interested in. And I had really useful discussions there, which shaped a lot of the subsequent research and grants that I put forward. And so it also led to the inclusion of a dementia advocate who was on that panel as a co-investigator on my Dementia Australia postdoctoral fellowship grant and another subsequent grant as well. And so some of the things that emerged was that firstly, diagnostic pathways, they're not linear. It's some individuals experience multiple consultations and referrals and even incorrect diagnoses before receiving a definitive diagnosis. And others were sharing with me experiences of how they had a GP and the GP really didn't understand what was going on and didn't know who to refer to or what. And then they changed GPs, and then immediately they were connected with all sorts of different resources and pathways and networks. And so it really emphasized the importance of GP awareness and clinician awareness of these symptoms. So this led to my application, my postdoctoral fellowship for Dementia Australia, which is a 3-year, provides 3 years of research funding. And it's fundamentally what I wanted to do was embed what I've learned with the Bayesian analyses, in addition to the rich networks I've established with people with lived experience, into this project design. So the first project was to provide an evidence synthesis and systematic review to find what are the factors that contribute to diagnostic delay and how so, but also conduct focus groups with people who have lived experience, carers, partners, and identify what they say the factors are, and embed these together to sort of within the Bayesian framework. So you have the systematic review and then the focus groups of people with living experience, and that contributes to the prior distribution. And then the data, which is the frontier data set, is the likelihood, and then that allows you to have the posterior distribution, which is the updated knowledge. And then finally, I wanted to ensure that we could reduce the time to diagnosis so that people could have access to the care that they needed earlier or as soon as possible, and also possible treatments. So the third part of the project is a policy translation with an advisory group. And so that the goal there is to try to seek clear recommendations based on the findings to influence policy. And so if I'm successful in this, I'll find out in December. So if I get a Christmas present, it'll be this postdoctoral fellowship. So look, that's one of several grants that I submitted. I'll probably leave it there in terms of that. But what I want to emphasize is that also the Bayesian analysis is just one of many things I upskilled in. I also upskilled in learning how to do simulation studies in R for power analyses and other statistical methodology. And so that led to my involvement in several grants. So across the OSP, I was able to have the time to focus on developing these skills. So there's over $8 million of funding I've been able to apply for. 5 of the grants, 2 of the grants I've led, which is $500,000 of funding as chief investigator, 3 as co-investigator, 1 as associate investigator. And the one with Rick Dawson is connections through CART, but also he's located in Sydney University. So all of these grants were only possible through the time that I've had at OSP, and particularly I've developed them whilst at ANU and working intensely there. With the publications, I've shared the first publication with you, the results from that, which will be published very, very soon in the coming weeks in Alzheimer's and Dementia Diagnosis, Assessment, and Disease Monitoring. So it's a Q1 journal. And so, but there are also several other publications I was able to contribute my time and expertise to whilst being on OSP. And so OSP has really been valuable for me to improve my track record in these areas. There were also presentation and outreach opportunities I engaged in. So at ANU, I delivered a seminar about my research in a lot more detail. I was invited to University of Technology Sydney, where they had a Gen AI Enhanced Summit. And so I delivered a presentation there as well. I came back to UC for a day for the HEAL National Research Network Future Leader School. And so I did a talk there, and everything that's in red is sort of hyperlinked. So you can find the talks that have been recorded there, and also engaged in media interviews as well and outreach in those areas. It also gave me the time to complete my senior fellowship application for the HEA. So that was really useful. And there are a whole bunch of factors that led to that. There are changes occurring in the university as well. But it allowed the focus time to allow for that application to be completed. And it was a really useful process. So if anyone's interested, let me know. I'm happy to help support with your application as well. So what does life after OSP look like for me? Well, there's essentially I want to and continue to use the Bayesian methods that I've developed and expertise I've developed so far to continue in my research. So I have ongoing lead authored publication in UK Biobank dataset. I've also working on that systematic review for the symptom onset to address that important question there. I aim to reapply for NHMRC investigator grants in 2027, which, hopefully with my improved track record and strategic focus aligned with CARET, will help with the success of that. And also ARC Discovery grants. That's DECRA for 2027. With Frontier, it's been great as well to have the continuity. So Olivier's continued to meet with me every week and chat about the research that I'm doing. So that's been great. And also I continue to speak with the members of Frontier through fortnightly lab meetings as well. So that's been really useful. And there's research affiliate status with UCID and ANU, so that allows the structure for those collaborations to continue. I really want to continue to strengthen and expand my lived experience partnerships. That's been really rewarding and very different to what I've done to date in my research, and I've found it incredibly useful. And so I'm hoping to continue in that space and develop further. And the presentation I did at UTS for that Gen AI Summit led to someone in that venue works for New South Wales Health, and so they've invited me to deliver a Gen AI workshop for New South Wales Health. And there's also the possibilities of integrating Bayesian methods in UC teaching programs and working out ways in which it can be used to upskill our graduates. And I think it allows for greater employability in a whole bunch of different domains that use these sort of analyses. And of course, yeah, I'm happy to support anyone who's interested in a HEA fellowship. So thank you, of course, to dementia advocates who really shaped the direction of the research and provided a lot of value in terms of my thinking about the questions. The CARET, Center for Aging Research and Translation, who motivated the change and expansion of my research area, which I probably wouldn't have done otherwise, and it's been really rewarding. Professor Olivier Piguet and Nicolas Chaburn, who hosted me at both UCID and ANU, Frontier colleagues who've been immensely supportive of any research direction. Ramon, David Fox, James Burrell, neurologist. There's so many people there. I think academia is full of rejection, and so my journey to OSP is not immune to this. So I applied in the year before and wasn't successful. And I'm really grateful to Stuart for, in that first round, he sat down with me and had a conversation about how I could strengthen the application, and I resubmitted and was able to be successful this year. So Stuart is acting dean when I applied, and it was successful, and also Rachel Gibson for continuing that. Phil, of course, OSP is not possible without discipline lead support. So I'm immensely grateful for that. And colleagues in discipline psychology. There's many who've taken up the work that I was doing whilst I was on OSP. James Neal took on the Gen AI community of practice. Many others took on roles, particularly in the Faculty of Health as well, for the different roles that I'm on in terms of Ps and whatnot. So thanks so much for everyone who's. And I think that the final thing to say is the story behind OSP is this. There's a lot of sacrifice and contributions that come from my family. So I thank them for allowing me to do OSP, and that's it for me. So thank you very much. Thanks for your attention. Hope you enjoyed the talk. If you have any questions, let me know. Yeah, that's it.